So, welcome everyone to today's New England PTTC webinar, focusing on kind of an overview of what is out there currently in the New England drug supply. Our presenter today is Robert Lawler Jr., a drug intelligence officer with the New England HIDA. I have a couple of notes before we get started. My name is Kristen. I am the distance learning coordinator with the New England PTTC. The New England Prevention Technology Transfer Center, or PTTC, is a program funded by SAMHSA at the U.S. Department of Health and Human Services. The contents of our trainings, such as this one, are those of the authors and not necessarily representative of the views of or endorsement by SAMHSA or the U.S. government. Just a couple notes on the PTTC network. In the New England PTTC, we are one of 10 regional centers providing training and technical assistance services to support the substance misuse prevention workforce across New England, as our regional partners do the same. We also have a network coordinating center. If you are joining us today from outside of New England, I do encourage you to also connect with your regional center, as they might have some region-specific resources available to you. But we always welcome folks from New England and beyond in our New England PTTC webinars. Our goals are to improve implementation and delivery of effective substance misuse prevention interventions through training and technical assistance as programs like this one and a variety of other resources available to you all. Just a couple notes on today's webinar. We are in a Zoom meeting format. We encourage you to use the chat. If you would like to introduce yourself and let us know where you're joining from today in the chat. It's always nice to see where folks are connecting from. We will ask you to remain muted during the webinar unless if you're invited to unmute for Q&A or anything like that. But since we do have a larger group here today, that's helpful. I will send out an evaluation survey at the end of today's webinar. We appreciate your help in completing those. It's helpful to us and in our planning purposes and for our funding agency as well. And I will be sending out certificates for this webinar as well. I'm actually going to try to get those out to you all before the end of the day today, fingers crossed. So you'll be getting those via email from me as well. I think that's it from me for today's webinar. So I'm going to go ahead and hand it off to Bobby, our presenter. He's a great presenter, knows a lot of very well versed in all things to do with drugs and the drug supply in New England. So happy to have him back sharing with us again today. So the floor is yours. As we go, folks, if you have questions, please drop them in the chat. We will try to save a few minutes for questions at the end of today's webinar. But if there's any things that you need clarified on the slide or as we go, we will try to address those as we go too. So we'll do a bit of both, but any big questions, we'll try to save a few minutes at the end. Okay, all yours, Bobby. Thank you so much.
Thanks, Kristen. And you can see my screen and hear me fine? Okay, great. So, as Kristen said, my name is Bob Lawler. I am a drug intelligence officer with New England HIDA and the Overdose Response Strategy. I am the Connecticut drug intelligence officer currently for this program. And, you know, like Kristen said, this is really a New England overview. And as Connecticut is the gateway to New England, we get a lot of insight that I share with my partners and other colleagues throughout New England, because a lot of times we are the first people to see it. Being in such close proximity to New York, which is one of the major drug hubs, if not the major drug hub in this country, we get a lot of insight into what is it going to occur in the broader drug environment very quickly. Um, where we get our information from is really through a lot of our partners. And the way we currently work in Connecticut is we bring in a lot of information, forensic information, toxicology information, field testing, law enforcement bulletins, public health bulletins, classified material from our federal partners, a lot of data collection, research from major universities, not only here in New England, but across the country, briefings and incident responses. And also, I already mentioned, but a lot of the information that is really pertinent comes from classified or law enforcement sensitive bulletins and situational awarenesses. And we get all this information from our partners, which you can see on the other side of the screen, whether it's, in Connecticut, it's the State Police Task Force, the DEA Task Force, the FBI Task Force, um, the Department of Health, the Department of Mental Health and Addiction Services, at all the different levels, the federal, state, and local and tribal levels. This is where we're getting all the information from. And then we take it in. And one of the unique things about this program is because we are funded partly by the Office of National Drug Control Policy and partly by the CDC. On the law enforcement side, we have clearances to review classified and secret materials. And then on the public health side, we have MOUs to actually see public health data. And we are really some, if not the only people who can actually see both sides of the problem, see the law enforcement side and the public health side. And then a lot of what we do is bringing those two sides together, looking at the information, the intelligence, the data we're seeing, and inform both sides of what is actually occurring and what this data means. Because while data is great, if you don't have context to what the data is really telling you, sometimes it ends up being useless information. So in Connecticut, we've seen a pretty remarkable drop in fatal overdoses. We've seen about a 45 to 46% drop since the height of 2021, where we saw 1,524 overdoses. Last year for 2025, we had 836. And we've had pretty good, with the largest decrease being from 2023 to 2024. But each year since then, 2021, we've had a decrease. So over the last 4 to 5 years, we've seen a 45% decrease in fatal overdoses, which translates to lives, right? And this is what this all is about, trying to save lives. So that's pretty great. And it's really a testament to everybody who works in this space, no matter what your position is or what you do, whether you're a prevention person or you're working in a treatment recovery facility or somewhere in between. We all play a part in decreasing this number and working with people with a substance use disorder or some other underlying issue that may affect them down the line developing a substance use disorder. So it really is a whole community that really works on this program, on this problem, and we can see the results when what happens when we all work together. So in Connecticut, some of the key findings from last year, I kind of mentioned the overdoses fell, and we've seen the fatal overdoses drop from to 40 by 45%. One of the unique things we've seen, and this is where I think, it's important to understand the context and not just look at the data. We've seen this kind of convergence of fentanyl involved in deaths and cocaine involved in deaths. And they're almost even now. We're at 69.1% of all deaths involve fentanyl and 58.6% involve cocaine. Again, this means it's involved. It doesn't mean that's the drug that killed them. And in most cases, the drug that killed them is fentanyl. The thing we got to understand when we look at demographics, the demographics are shifting from the younger white male who is dying to the older black male who is dying. So that's a little bit of a reason why cocaine is involved. The other issue that this is where it's important to understand the context of things is fatal overdose is a toxicology finding, which means your coroners, your medical examiners, they're looking at biological samples to determine what is in the body at the time of death. So they're talking blood, urine, whatever. And drugs that are in the body at time of death doesn't mean those drugs were contaminated. So, like one of the issues we see is that a lot of people think because the cocaine involved deaths is rising, oh, that must mean the cocaine supply is adulterated. And what we see here in Connecticut, and we have pretty good surveillance systems here in Connecticut. We have law enforcement seizure data from our state and local partners, law enforcement seizure data from our federal partners. We also have a pretty robust community drug checking program here in Connecticut. And what we see is that less than 3% of the crack and cocaine supply is actually contaminated with fentanyl. And when it has some fentanyl in it, it is at amounts that are really trace amounts that we attribute to unintentional cross contamination. And what we mean by that is that, people who sell drugs, they're not sterilizing their equipment and they sell multiple drugs. So people who sell cocaine will also sell fentanyl and other drugs. And when they're mixing or bagging up their cocaine or their fentanyl, in between, they're not sterilizing the table surface, the bowls, the spoons, whatever they're using to mix their product and bag their product. They're just going, okay, now it's time to mix my cocaine or my fentanyl from after completing the other one. And this causes some unintentional cross contamination that we will see in the supply. But again, it's at less than 3% of the supply. So the issue isn't cross contamination, and we'll get into this a little further down. It's really polydrug use. People with a substance use disorder aren't using just one drug. They're using fentanyl or an opioid because they don't want to go into withdrawals and get sick. And they're using cocaine or another stimulant to, mitigate the effects of fentanyl, mainly the drowsiness and the sleepiness that comes with it. And, while there are other stimulants in the New England area, the predominant stimulant in all of New England is really cocaine and crack. Um, New England is a hub for cocaine and crack right now. We're seeing a lot of it come in from the Caribbean corridor. So that is a major issue. The other issue we're seeing um, is carfentanil. In Connecticut, we've seen carfentanil jump from, you know, 10 overdose deaths in 2024 to 31 in 2025. Carfentanil is an interesting issue because one of the things we don't see is we're not seeing non-fatal overdoses either the week before or the week after a fatal carfentanil overdose has occurred to increase. And when you think about the strength of carfentanil, this is, one of the questions I ask as a drug intelligence officer is, okay, we have 31 deaths. Why don't we have 310 deaths? That's how strong carfentanil is. And why aren't we seeing more non-fatal overdoses, in a short time span of when we're seeing these fatal overdoses? So it's actually a very interesting question from a lot of different lenses, but that's one of the issues we're paying special attention to. So again, I kind of mentioned this a little bit, and I think this has historically been the way. Males have a higher mortality rate than females. The male rate in Connecticut is 30. The female rate is 13.5. But again, all overdoses have declined across all demographics. So, again, shout out to everybody. Some of the major substances we are tracking that are really playing some havoc in the illicit drug environment currently are illicitly manufactured designer benzodiazepines. In 2025, we had 42 deaths attributed to, or yeah, they had some play in the death. In 2024, it was 39. So again, another increase. Kratom has now become illegal here in Connecticut. I don't know about whatever state you're in, but we are starting to see kratom derivatives pop up as a in the the death toxicology. In 2025, we didn't have any, but so far in 2026, we had two. And I did double check with our Office of Chief Medical Examiner. If kratom was involved in a death in 2025, it would have been picked up by their toxicology screening. So the zero fatal overdoses that were had a kratom involvement um, being zero wasn't because of a lack of testing or identifying the substance in the toxicology results. Medetomidine we are seeing here in Connecticut, um, and we are seeing xylazine. Xylazine has decreased in the Connecticut drug supply very sharply. We're not seeing it at the same rates we have. We're also not seeing it medetomidine replace xylazine. I know, like in the greater Philadelphia area, they've seen xylazine be predominantly replaced by medetomidine. And we are not currently seeing that here when we look across the region. So again, some of the tracked substances we really pay attention to is carfentanil, designer benzodiazepines, nitazines, which is a new and emerging synthetic opioid. Um, I think almost all of the New England tri-state area states have at least identified nitazines and confirmed their presence in their state. However, they're not at the levels that fentanyl is. So nitazines would really be a fentanyl replacement, and we're not seeing it anywhere near those levels. And then the kratom issue is another one we're keeping a close eye on. So then this is something, and unfortunately, I always thought this was good data, and we won't get into politics, but we all know the reasons why CDC hasn't updated these stats from the suitors dashboard. Um, but I could tell you, at least here in Connecticut, we still see these data points as the major issues when we're looking at fatal overdoses. And I've always, because, and rightfully so, we talk a lot about the unhoused population that has a substance use disorder. But when you really look at the data, the issue is, people are dying in homes and in dwellings. And I think this is a byproduct of the unhoused community in a lot of ways has more community than people who live in their own apartment or dwelling or house or whatever, because they live in such close proximity to each other that they look out for each other, right? And when you have a substance use disorder and you lived at home or you live with a loved one, and the stigmas there of, maybe you went through a program and your loved one thinks you're in sobriety now and you've relapsed, which is, is common and perfectly natural in the cycle of addiction, but you you don't you're not sharing that you're going to use the way somebody in an unhoused community might feel. No stigma and going to tell their tent mate or whatever, hey, I'm going to go use or come use with me, and we'll take turns watching each other. And then the other big data point, I think, is the potential opportunities for intervention to prevent death. And this is really what the stat drives at, is that, you know, if people were sharing that they were going to use, there's somebody in a close proximity to check on them and intervene. And a lot of the times the example I use is that, a loved one will go and say, hey, they're going to go take a nap or they're going to go use the restroom. And the other loved one in the house is, cooking dinner or cleaning or doing, a normal household chore. And that person who went to go take a nap or go use the restroom is actually going to use. And then that person, unfortunately, succumbs to a fatal overdose because the other loved one in the residence didn't know that they needed to go check on them, right? So again, a lot of the stigma, shame that's a driver in fatal overdose is at play there. So I always look at this data as some of the most important and telling data that there is out there, because if we could figure out this issue, we could probably then drop the fatal overdose number by half again. So, I think it's an important issue to talk about. I'm going to skip this for time, but so some of the major issues in Connecticut currently, and really this region, are fentanyl, cocaine and crack, fake pills, methamphetamine, and I'll go into methamphetamine in 1 second, and then synthetic cannabinoids, and in Connecticut, we are again seeing, and it's really a cycle here, is PCP becomes an issue. Seems like every 18, 24 months or something, it pops up for a period of time. But it is a very common used drug in our inner cities here in Connecticut and the Northeast. And the methamphetamine issue is interesting because it's not, when most people hear meth or methamphetamine, they think of crystal meth, they think of Breaking Bad. But what we are really seeing is meth in pill form and meth in powder form. So meth being sold in replacement or of cocaine or mixed with cocaine, and then meth pressed into Adderall pills and pressed into ecstasy MDMA pills. And really the pill um, delivery system is the most prominent for methamphetamine. We do see crystal meth, but the crystal meth that we see is predominantly isolated in the male for male sex party scene. That's where we see the most of the crystal meth here. And the rest of the meth we are seeing, but it is growing, is in pill form and then some powder form. So that's a major issue. These are the top fake pills that we see. So these are if you go left to right, you'll see the blue M30 oxycodones. Um, those are just fentanyl pressed pills. The 2 milligram Xanax bars. So the issue with the 2 milligram Xanax bars, 80% or 8 out of every 10 of them are being identified as an illicitly manufactured designer benzodiazepine. About 20% or 2 in 10 are coming back as fentanyl. So the issue with that is if, while there is a lot of poly drug use, a younger person may just be looking for a Xanax, a benzo. And if they get one of those 2 in 10 fentanyl Xanax bars, that could be a major concern. The next one is the Adderall pills. And again, these are coming back as methamphetamine. And then the ecstasy MDMA pills are coming back as methamphetamine. And the ecstasy MDMA pills, those are been coming back as methamphetamine, at least here in Connecticut, for over 10 years. Um, and again, the other thing I want to stress about the pill environment is there is no more pharmaceutically diverted pills for sale on the street, right? Um, so, it's not 2009 or the mid 2000s where, you know, drug trafficking organizations were getting a bus and putting 15 people on it and going to the pill mills in West Virginia or Florida and coming back with thousands of fake pills to sell on pharmaceutically diverted real Oxycontin to sell on the streets. What we're seeing is pills that are pressed with fentanyl or other illicit drugs to resemble a prescription drug. Um, and I think that's important to understand. And again, I'm not saying that no diversion occurs in Connecticut or really the Northeast tri-state region. But what we see when we talk about diversion is we see that, and I'm just going to, use myself here. If I have an Adderall prescription and let's say I'm getting 30 pills a month, I have consistent customers. So, and I'm just going to use people I see on the screen right here. I'm going to use Kristen and John. They are my two customers. Each and every month, they each buy 10 pills from me. I take that money and I supplement what I've sold with illicit drugs and still make a profit. That is the type of diversion we see. That's not, oh, Bob Lawler, is getting my 30 pill script. I'm going to sit on a corner in some major city and sell my pills, that way. The other diversion we do see, and again, I don't think this is going to shock anybody, We see people who work or have access to drugs like fentanyl or other drugs who work in some sort of medical setting who will steal or divert those drugs for personal use. It's very rarely we see those people doing that for sale to sell to somebody or sell to other people. It's usually because they themselves has a substance use disorder with that particular drug, and that's is how they're obtaining their drug. So that is really how we really see diversion. So fentanyl, right? That is the big issue here in really everywhere in this country because that is the drug that is really driving fatal and non-fatal overdoses. And because it's such an acute acting drug, and the reason for that is because it's 50 to 100 times more potent than morphine, but also, and probably more important, it's so lipophilic that it absorbs through the blood-brain barrier very quickly. And what this means is that because it absorbs through the blood-brain barrier very quickly, it also rapidly affects the central nervous system, which causes that rapid respiratory depression. And we know from the research, and this is all stuff you could look up, is heroin or and even oxycontin, but mostly heroin studies show that a heroin overdose could be lethal in about 20 to 30 minutes, where fentanyl can be lethal in less than five. And whenever we give any types of presentations and we talk about fentanyl, one of the things I like to stress, no matter how controversial it is you can't be afraid to offend somebody. If you suspect somebody has a substance use disorder or, you know, maybe battling substance use and they appear to be nodding out, you can't be afraid to check on that person and make sure they're okay. Because being like, you know what, I don't know, let me go get a glass of water, let me go get a soda, let me go take a cigarette break, let me go, send a couple emails and I'll come back in 15, 20 minutes and check on that person. Well, that can be too late. And also, again, I'm going to talk for most of New England. I know there's people from other parts of the country and you'd have to check your laws there. Most of the New England states have pretty good Samaritan laws that cover the calling of 911 if somebody's having an overdose. And when we get into what is really in these substances, you'll understand why I'm stressing this. Even if you have naloxone on hand, I and every situation is different, but I highly encourage you to call 911 just because of how volatile and deadly this illicit drug environment can be. Um, and yes, the fentanyl is probably the primary driver for the decrease in the respiratory depression, but there are other drugs in whatever that person took that can also be at play that are causing issues also. Xylazine, again, this is a major issue in most of the area. It's an alpha 2 agonist. It's not a controlled substance. It's a veterinary product, so it is used in veterinary services, but it also causes central nervous system depression and respiratory depression. It increases the effects and decreases frequency to redose. So what this means is that, and I was talking earlier about the rapid absorption through the blood-brain barrier. That not only causes a quicker high, but it also um, expels through the body at a quicker rate than normal heroin or even OxyContin did back in the day. And what xylazine does is so if you have this quicker flow through the body, then you would need to redose more quickly. And xylazine prolongs that. So xylazine decreases the crash hill and elongates it a little bit and causes an issue where you don't have to redose as quickly. That's one of the reasons why we see it in the illicit drug environment and people kind of are okay with it is because of those issues. But it's not an opioid. It doesn't attach to the opioid receptors. so it won't respond to naloxone. I mean, yeah, it doesn't respond to naloxone. However, we don't really see it in without fentanyl. So just use the naloxone anyways, because at minimum it will knock the fentanyl off the opioid receptor, help restore breathing. The one thing you got to understand though is you're not going to have that quick alert because xylazine isn't a sedative. So the person could still seem sedated or asleep. You got to check for the breathing and make sure that breath has been restored, and that's important. Um, the other thing, you know, talking about is xylazine. I was reading a study this morning, and they thought xylazine had a shorter half-life. I mean, a much longer, yeah, a shorter half-life, and didn't stay in the body that long. But this new study is telling us that it's staying in the body almost 6 hours. Um, so the half-life is 6 hours on xylazine, which is another interesting fact that, again, a lot of these substances are new to the illicit drug environment. And like anything, it takes time for researchers to put together a study and really vet it out and conduct it and publish it so we understand these things. So, a little bit of trigger warning. These are what xylazine wounds look like. Um, if you're working with the substance use community or you see somebody with these wounds, um, encourage them to get some sort of care. These wounds can get infected very easily. Um, you know, if possible, you know, refer them to medical care. Um, the other thing I usually stress is, we all know those community organizations that work with people with a substance use and take care of the people with a substance use disorder. Um, and at least I know here in Connecticut and a lot of New England, we have really great organizations that do that. And a lot of times those community organizations know how to build trust with the substance use community and know how to treat these wounds, and also know the clinics or the doctors who are judgment free and will not provide the stigma that a person with a substance use disorder has. So if you can't connect them to a clinic or another medical service to get these wounds looked after, maybe the another option is those community organizations that provide a lot of services to the substance use community. Again, apparently hydrogen peroxide exacerbates the wounds, so they stressed not to use it. Use just good old fashioned soap and water. So that is another issue there. Again, medetomidine is really a bigger, badder cousin to xylazine. Um, it's about 100 to 200 times more potent than xylazine, has a longer duration of action, and acts on both the central and peripheral nervous system. So it's a pretty ugly adulterant in the illicit drug environment. And it's another reason why we keep tabs on it. These are some of the withdrawal systems we see with medetomidine: nausea, tremors, anxiety. Um, One of the bigger concerns is tachycardia and hypertension. Um, the other, and I haven't really fully understood why. One of the other things we see with medetomidine is we don't see the wounds associated with medetomidine like we do with xylazine. So that's I don't know if you want to call it in. I find it interesting just because if they're in the same family, why aren't we getting sort of the same results? But that's what we're seeing with medetomidine. Carfentanil, again, this is probably the most deadly drug out there. It's 100 times more potent than fentanyl, 10,000 times more potent than morphine. Again, it was originally developed. They're not actually using carfentanil anymore. I think they're using another fentanyl analog called remifentanil to work with large animals. So think an elephant, think a lion, think of something, a grizzly bear. You know, vets and zookeepers and people who work with large animals, they needed a way to treat these animals safely, and that's where carfentanil came in, so they can sedate these animals and work on them and give them the treatment they need, even if it's cleaning their teeth, right? They need some way to be able to do that safely, without them themselves getting injured. And like I mentioned, earlier, we're seeing the carfentanil that's rise here in Connecticut, but also I know Mass is seeing it. I know New York is seeing it. I think New Hampshire is seeing it a little bit. So there's other states that are seeing this, and it has no rhyme or reason. It's not really following traditional drug trafficking routes of where these deaths are popping up. They're not really clustered anywhere to really give you a sense of, is there one drug trafficking organization that mixing carfentanil in their illicit drug supply? Is there some other reason? So again, from my lens, it's a really interesting issue because it kind of doesn't make sense, or at least um, drug intelligence officers like myself or at the federal level with DEA or Customs and Border Protection and other agencies haven't really figured out what is going on here and why we're seeing carfentanil the way we are seeing it. I mentioned illicitly manufactured designer benzodiazepines. Again, we're seeing it. It binds to the GABA receptors, but this is becoming a major issue. Um, in the country, the replacement of diverted drugs. You're always going to have people looking to the black market for drugs. And if you're looking for a benzo, just the same way, if you're looking for an Adderall, you're probably not getting what you're looking for. You are getting a fake pill that is pressed to resemble that. And I think that's something we all need to wrap our heads around. I touched on nitazines a little bit. They're becoming an issue in a lot of parts of this country. They're not an issue currently in any of the New England states that I am aware of, or even the tri-state region. But I'm pretty sure we've all, or most of all the states have at least identified it, either in law enforcement seizures or fatal toxicologies. Um, but the main issue with nitazines is it adheres to the opioid receptor stronger and has a higher affinity, which means it activates it at a higher rate. Um, so one of the ways to think about it is, fentanyl is like a Velcro. It sticks very quickly, and but a good strong tug, it'll come off. So in that good strong tug is naloxone, where nitazene is like a super glue. It takes a little bit longer to latch on, but once it does, it's harder to come off. Again, there's a lot of discrepancies and there's limited uh, research around naloxone with nitazines, but for the most part, it does seem that naloxone will work. It'll probably take you 2 doses or maybe 3 doses to actually knock the nitazene off the opioid receptor. But again, it's something that there's not really great research on as of yet. I'm sure in the next year or two, we'll probably get something really good out there on nitazines and naloxone. But again, this is a major issue that I think we all need to be aware of. I talked about methamphetamine use in the region earlier. And this is, to me, outside of the fentanyl issue, I think these two issues together are probably one of the major issues that people need to understand. So we have polydrug use and polysubstances. So polydrug use is the use of multiple drugs, in close proximity to each other or even throughout the day. So again, this is generalization. Every person who has a substance use disorder is completely different, but just as a generalization, if I have an opioid substance use disorder, a lot of times I am just using opioids to not go into withdrawals and not get sick. So I wake up in the morning, I am using whatever is my normal amount of opioids. I will then, in close proximity, take a stimulant. If you're in this region, it's probably cocaine or crack, to mitigate the effects of the opioid, right? And then I can go about my day. And this cycle happens multiple times a day. The other thing we see is that people with a substance use disorder will do this multiple times a day, but then they'll also add in like alcohol or cannabis and maybe a benzo And that, those three are kind of what they use to, party, get numb, whatever, wind down, whatever, whatever term you want to use for that. You know, to me, it's the same as, whoever coming home from work and having a beer or, having a glass of wine, right? At some point, you probably just want to relax for a little bit. And there's some, usually in this culture, there's a substance involved in that, right? Um, and that's what we see. So, and this is from the Office of Chief Medical Examiner. And this is when we look at fatal toxicologies, and it's important to understand toxicology is what is in the body, not what is in the substance. And I think that's where a lot of people get in trouble is they equate toxicology results to what is actually in the drug supply and what is in the particular substances that are sold on the street. And this is common, at least here in Connecticut, and I'm pretty sure in most of New England. You see, when you look at fatal toxicology, it is a laundry list of drugs that is in the person's system when they had the unfortunate fatal overdose. And to be honest, the only time we really see a single drug issue that caused the fatal overdose is almost exclusively ethanol and alcohol, right? Because a lot of times when you're at that stage of alcoholism, that is really the only drug you're using. And that is what we see. We don't really see just fentanyl, just cocaine, just methamphetamine. It is always this laundry list of substances that are in the person's system at the time of their passing. But then, and I think this is more important, when we look at law enforcement seizure data, again, we're testing so there's two levels of law enforcement seizure data. There's large seizure data where, like DEA is seizing 100 kilos of substances coming over the border or from a cartel or a major drug trafficking organization. And that is done by the DEA lab. There's a new one in New Hampshire. There's one in New York. There's a couple around the country. And yes, we see the same thing there, but more often than not, it's not as pronounced as this. But when you look at the substances people are using on the street, this is what you see. So this is one Ziploc bag being tested, one wax fold, one twist corner, one, vial, a one pill. This is what we see, this laundry list of drugs. So even if you just look at, the upper box and the lower box on the left-hand side, you see fentanyl, heroin, tramadol, chlorofentanyl, xylazine, caffeine, sugar, and procaine. And the one underneath it, you see cocaine, methamphetamine, and acetaminophen. This is common. This is what we see. So if you go back to the slide before when we were talking about poly drug use, so then add on to that the substances that are each of those things. So again, going back to that same scenario, if I wake up in the morning and I am taking my opioids so I don't go in withdrawals and I'm taking that upper box on the left, I'm introducing into my body fentanyl, heroin, tramadol, chlorofentanyl, xylazine, caffeine, sugar, and procaine. And then in close proximity to that, I am adding in cocaine, methamphetamine, and acetaminophen, right? And then, if we just move over to say, I don't know, the third box, right? Where you have just the third row here where you have just crazy different drugs in each of these. If the next time I need to redose, I am taking a substance that has cocaine, fentanyl, parafluorofentanyl, caffeine, mannitol, levamisole, and then I am taking cocaine, fentanyl. Like you see how this all adds up in the body. And as somebody who was in law enforcement for 20 years, I don't know how I became sort of a research geek, but I like looking and reading research and evaluating research. There's not a lot of good research on what this does, not only to the body from a public health perspective, like what does this do to all these different toxic substances? What does this do to the person's body? But what does this mean for the cycle of addiction? And what does this mean for how we treat a person with addiction? Is the gold standard really the gold standard of how we treat an opioid use disorder when this is, and I'm not saying it is or it isn't, it's just a question I have, and again, I don't think there's, I at least haven't been able to find it. And if you know of some studies out there that talks about this issue, please share them with me because I'd be interested. But I looked, There's no real good research out there about what this means for the substance use community and how we can adequately treat them and care for them with what is going on in the illicit drug environment. And I know we're running out of time here and we want to leave some time for questions, but so I'll pretty much end here. This is coming from three different sites in Connecticut where we have community drug testing. Community drug testing, they're testing the drug trash and drug remnants from their clients who are, you know, people with a substance use disorder. And again, we see this same laundry list of drugs, right? You see ketamine and methamphetamine, MDMA, desochloroketamine, cocaine. The next one, cocaine, xylazine, ketamine, fentanyl. And then, on the right, it's just, it really is a grocery shopping list of just substances that are in this sample, right? Fentanyl, xylazine, metamethadone, cocaine, fentanyl, and it just goes on and on and on. And this is what we see. And, I put out a public health alert on Monday for Connecticut, just to show you how bad this is. One of the law enforcement agencies made a major seizure of drugs. And when they tested the substance that was in, the drugs that were they seized, it was a mixture of two different nitazene analogs and two different illicitly manufactured designer benzodiazepines. And that was what was in this major system or the seizure already. And they had, according to the investigation that is still ongoing, the instructions were to further adulterate this even more. So to add other substances to make it go from hypothetically, 100 grams to 300 grams, right? So add another 200 grams of substances and adulterants to this mixture to increase your product load and be able to sell more and make more money. But when you think about just that mixture, two different nitazenes, two different benzodiazepines, and then telling dealers to actually add more substances to it, you can understand how this becomes one of the major issues when we're talking about overdose, caring for people with a substance use disorder, and just the overall addiction environment that we're seeing in this country. Um, and I wanted to leave time for some questions. We're at like the 10-minute mark. So this is me. You know, if you have any questions, please feel free to reach out to me. Um, I didn't make this. My partner made this. Who's a public health analyst, but there's QR codes all over this if you want to look at the ORS program website or connect to us. But really, it's rlawyer@anyhida.org is the main email address for me. And with that, we'll open it up for questions.
Yeah, thank you so much. Lots of info as always. I know it's yeah, just always interesting. I think you're in good company here with other folks who are have either always been or have become research the research nerds. So you're in the right room. If folks have questions, you can either put them in the chat or we do have a minute here. So if folks want to raise your hand and ask a question, I'm actually going to stop our recording now.